potatoes of our study time period, but we had to exclude 26 eyes due to less than 5 years of follow-up. However, we included all indications for surgery. Again, our primary outcomes were visual acuity and visual failure, which we defined as a sustained worse than preoperative vision or visual acuity. We also looked at risk factors for visual failure and the number of complications that these patients had. We assessed these with the Kaplan-Meier survival analysis, descriptive statistics, and the univariate Cox proportional hazards model for the risk factors for visual failure. What did we find? So sorry for the overwhelmingly large table 1, but let's walk through it. So first of all, our patients had an average of 7.2 years of follow-up in this cohort. Preoperative visual acuity in our patients was in between counting fingers and hand motions vision, and the most common indication for surgery in our cohort was limbal stem cell deficiency, with around 30% of patients having aniridia. Endothelial disease and post-infectious keratitis were the next most frequent indications for transplantation. Around half of our patients had the KPro as a primary graft, i.e. they had no prior penetrating or endothelial lamellar grafts. And of the patients that did have prior grafts, they had around 1 to 2 previous grafts before having their KPro. Patients with known glaucoma, there were around 60% of patients that had known glaucoma in our study, and around 10% with previous drainage device. So this figure shows the average preoperative and postoperative visual acuity, which again was around the count fingers, hand motions vision before the surgery, and was significantly improved for 6 years following the surgery in our cohort. I'm going to jump straight to the survival curves in the interest of time. Here we have the Kaplan-Meier survival curves. So figure A shows our visual failure, which we defined again as worse than preoperative vision. We found that at 7 years, around 62% of eyes still maintained better than preoperative visual acuity. Furthermore, at 7 years, around 40% of eyes maintained better than 2200 vision. When we assessed the risk factors for visual failure, we found 2 factors that came out in our analysis. One being a diagnosis of Stevens-Johnson syndrome, which increased visual failure by around 7-fold, as well as having a previous diagnosis of glaucoma before the KPro was implanted, which increased it by around 3-fold. Other factors, such as stromal dystrophies, trended to have a higher risk for failure, and patients that had a tube shunt implanted postoperatively trended to have a lower rate of visual failure. Again, the most common complication that occurred in our cohort was retroprosthetic membrane formation, which occurred in around 40% of eyes at 8 years. And the most devastating complications, which are extrusion of the device or endophthalmitis, occurred at around 8% and 9%, 8% and 6% of cases at 8 years. So, in conclusion, visual outcomes with the Boston KPro in our cohort were the best in the short and medium term between the first 5 years of surgery, where patients had an improved visual acuity from baseline, and over 50% of patients had better than 2200 vision. At 7 years, over half of patients still had better vision than they did preoperatively, and the best predictors for failure were a known diagnosis of glaucoma and Stevens-Johnson syndrome. And this is significant because in these patients, there really are no other rehabilitative visual options for their corneal blindness. And our cohort shows very favorable results compared to other published cohorts in the literature, with a quite high retention rate of 92% and a comparable complication rate. Thank you.
Thank you, Andre. I'm going to ask Taylor now to give us a talk on long-term outcomes following primary Boston KPro type 1 implantation. Taylor, thank you.
Thank you so much, Dr. Dagher. I'll just share my screen. There we go. Okay. Are you able to see my screen, everybody?
Yes, perfect.
Okay, great. Thank you. So thank you so much for the opportunity, Dr. Dagher. So I'm going to be presenting on primary versus secondary KPro. So secondary KPro being after failed PKP and long-term outcomes at our center. So this work was done with my co-residents, Dr. Christina Boston and Dr. Andre Sigiato, as well as with the wonderful supervision of Dr. Dagher. So I have no disclosures. So the idea was to look at long-term outcomes in comparing the two groups of patients, so those having undergone a primary KPro versus those who had undergone a KPro after one or multiple graft failures, looking at vision, complication rates, and device retention. So, So we began by looking at all the patients who underwent a Boston KPro, type 1, between 2008 and 2017, as per the same specifications as mentioned by Andre previously. We then separated the patients into two cohorts according to whether or not it was a primary or secondary KPro, including all patients who had pre-op vision less than 20/100, and all those who had visual impairment secondary to reversible corneal blindness, meaning that patients who had extensive maculopathy or retinal pathologies and things that would have limited their visual prognosis were not included, and those who had minimum 5 years follow-up. So just to show you originally the baseline characteristics for our group. So we had 40 patients in the primary KPro group and 42 in the secondary KPro group. Really, most of the factors were comparable. I'd just like to draw your attention to the difference in aniridia between the two groups. So the aniridic patients in the primary group represented 47.5% compared to 14% in the secondary KPro group. So we'll start with vision outcomes. So at each post-operative year, from years 1 through 5, vision was superior post-op to pre-op in both groups, both the primary and secondary groups. In the primary KPro group, vision was significantly better post-operatively than pre-operatively at each time point, so years 1 through 5, whereas the secondary KPro group showed a significant improvement in the first 3 years, and while better in years 4 and 5, it was not found to be statistically significant. When we then compared the difference between each group at each time point, so primary compared to secondary at each time point, there were no significant differences between each group. Next, we performed a Cox regression analysis looking at pre versus post-operative visual acuity, whereas Andre mentioned earlier, visual failure was defined as sustained worse than pre-op visual acuity. I mean, the sample sizes were within each subgroup were small, but of note, the two patients who had a chemical burn in the primary group retained improved post-op vision. And as Andre alluded to earlier, the patients with Stevens-Johnson syndrome, we had 2 in the primary group, both retained worse post-operative vision. So concordant with what was already discussed. And then to the right, we have the Kaplan-Meier survival curve looking at maintenance of the postoperative visual acuity compared to pre-op in both cohorts. And essentially, there was no significant difference between the groups. As you can see, the patients having undergone a secondary KPro seemed to have initially better visual acuity. And then with longer follow-up, the trend was sort of more positive in the primary group, but there was no significant difference between the two groups over time. All right. So next, in terms of complications, the patients in the primary and secondary group had 3 differences in complication rates. So with the primary KPro group being associated with more sterile vitritis, so 17.5% versus 2%, as well as more new onset glaucoma, so 35% versus 14.3%, and device retention. So device removal occurred in 30% of the primary patients compared to 10% in the secondary KPro group. So overall device retention was found to be significantly different between groups, with 70% in the primary and 91% in the secondary group, with a p-value of 0.03. So just to continue with device retention. So as we've seen, in terms of visual outcomes, we have sustained improved post-op compared to pre-op vision in both groups, with it being significant in the first 5 years in the primary and first 3 years in the secondary group. And that the device complications were globally similar, but that retention was significantly lower in the primary group. Just to show you here, the table on the left shows a Cox regression analysis looking at device retention in each group. And all patients who had endothelial disease, trauma, and chemical burns retained the device at final follow-up in the primary KPro group. And in the secondary KPro group, all patients with endothelial disease, infectious keratitis, and chemical burns also retained the device at final follow-up. Patients with limbal stem cell deficiency showed overall poor retention of this KPro in the secondary group. And patients who had a tube shunt in the secondary KPro group did not have any excellent patients, just some pertinent findings. And the figure on the right shows the Kaplan-Meier survival curve for patients in both cohorts. And as we can see, device retention decreased in the primary group after about the first 2 years postoperatively, while in the secondary group, it remained more stable over time. And this is with a p-value of 0.018. So some conclusions. The long-term visual outcomes between primary and secondary KPro were comparable. Both resulted in an improved vision from baseline at all time points, with a significance in the first 5 years in the primary and first 3 years in the secondary group. Complications were globally similar, with the exception of more stale retritis, choroidal detachment, and new glaucoma in the primary group, and with lower retention in the primary KPro group. Just a few things on this note. So in the literature, Dr. Dagher had previously published a study with 1 year follow-up looking at this group of patients, where we have some slightly differing findings in the sense that we have a lower retention rate as compared to the 1 year study. However, as we alluded to at the beginning, the indications for a primary KPro included patients notably with aniridia and limbal stem cell disease, and these patients are well known to not do particularly well with PKP, especially aniridic patients. And so knowing this, given the positive outcomes in our group, we feel that a primary KPro could be an excellent option for those patients, particularly those with aniridia, in which we know that a PKP is likely to fail. Thank you.
Thank you, Taylor. Excellent summary. Now I'd like to invite Dr. Sama Sebeti to speak to us about the fresh versus frozen corneal carriers for the Boston KPro. Sama does not need any introduction for this group. She's our stellar clinical fellow, and she is joining the Ottawa University in July.
That's so kind of you. Thank you so much, Dr. Dagher. It was an honor for me to work with the cornea team here. It's Dr. Dagher, Dr. Robert, Dr. Thompson, Racine, and Segal. And I'd like to thank Dr. Dagher in particular as my fellowship director for being a mentor who's been incredible to me throughout the year, and for the privilege of being able to participate in the work of. Thank you very much.
Thank you.
Apologize, I can't share my screen until the last one is off. Okay, there we go. All right, so I'll be presenting today on the 10-year outcomes of a randomized controlled trial of fresh versus frozen corneal donor carriers in Boston KPro type 1 surgery. So corneal disease, as many of you know, is the third most common cause of blindness globally. There's significant demand on a limited supply of fresh donor tissue for corneal transplants, with over 12 million patients on the wait list for corneal transplantation worldwide. Another issue is that there's significant cost associated with the procurement, storage, and transport of fresh tissue. So many groups have looked into alternatives to fresh corneal graft carriers, which include cryopreserved or frozen corneal tissue, glycerin preserved or gamma irradiated corneal tissue. And in this study, we'll be looking specifically at the utility of cryopreserved corneal tissue. So cryopreservation or freezing allows for longer storage time of donor tissue. It's easy to manipulate and suture. Dehydrated, it usually remains clear throughout the surgery. However, the freezing process destroys all viable cells, which include keratocytes and endothelial cells. And so the main utility of cryopreserved tissue has classically been for tectonic support in lamellar or penetrating keratoplasty. As has been described, the Boston KPro is implanted into a carrier corneal graft, which acts as an interface and facilitates suturing of the device to the host using either trephinated corneal tissue from the patient themselves or corneal allograft from a donor. But unlike for PKP, the graft selection for the Boston KPro of endothelial status because the visual axis through the optic of the KPro remains clear irrespective of the clarity of the corneal carrier. And so the team felt that investigation into the long-term safety and efficacy of frozen graft carriers for the Boston KPro Type 1 was warranted, given that supplies and cost of fresh tissue are prohibitive, and also because successful visual rehabilitation using the KPro is independent of corneal graft clarity, which means that fresh tissue with a healthy endothelium is theoretically not required. So the goal of the study was to compare the clinical outcomes of fresh versus frozen corneal allograft carrier type 1. So in terms of study design, all eyes that underwent primary KPro implantation by a single surgeon at a single center over the course of just over a year using a corneal allograft carrier randomly received either fresh or frozen carrier tissue. And this tissue allocation was essentially determined based on availability of fresh tissue from the eye bank on the day of surgery. Our primary outcome measure was device retention, and secondary outcome measures included best corrected visual acuity and complications. So 37 eyes of 37 patients were included in the initial study protocol with 2-year follow-up, and eyes were randomly allocated to either fresh corneal carrier or frozen corneal graft carrier. And of these 37 eyes, 22 of them enrolled in a 10-year extension phase, with 13 eyes in the fresh group and 9 eyes in the frozen group. So we can see here that when comparing the two treatment arms in terms of mean follow-up, baseline demographics, preoperative diagnostic category, and ocular history, there were no significant differences between the cohort in the fresh versus the frozen groups, with all p-values greater than 0.05. When looking at our 10-year outcomes, you can see that the rate of device retention was 92% in the fresh group and 78% in the frozen group, with no statistically significant difference. Postoperative best corrected visual acuity for the fresh group improved from 2600 to 2320, and in the frozen group from count fingers to 2125. And again, no significant difference was seen between the two groups in terms of postoperative BCVA. And in terms of complications, we looked at patients who developed retroprosthetic membrane, corneal melt, tissue necrosis, uveitis, glaucoma, and other posterior segment complications. And in terms of comparing, we see that there was a total of 27 complications, or 2.07 per patient over 10 years of follow-up in the fresh group versus 21 total complications, or 2.33 complications per patient in 10-year follow-up in the frozen group. And again, the comparison showed no statistically significant difference in the complication rate either. And so in conclusion, we can say that fresh and frozen corneal allograft carriers offer similar clinical outcomes for KPro implantation in terms of device retention, visual rehabilitation, and rate of complications. And so this knowledge can help to advise optimal use of corneal donor tissue, spare the fresh tissue pool for other keratoplasties that depend on a healthy endothelium, while those donor corneas that are unsuitable for endothelial replacement and would have otherwise likely been wasted or discarded can serve through the use of cryopreserved tissue as effective carriers for Boston KPro implantation. Thank you very much.
Thank you so much, Sama. That was a great talk. The next presentation is by Dr. Roy Daoud, who is currently our research fellow, but as of July will be our clinical fellow at the SHUM. It's a pleasure to have him move on to the next role. Dr. Daoud is going to speak to us about corneal melts in KPro, a very important topic.
Okay, good evening, everyone. Can you hear me?
Yes, very well, Roy. Thank you.
Okay, thank you. First of all, I'd like to thank Dr. Dagher for this great opportunity. I'm going to be talking about management of corneal melt in patients with Boston Keratoprosthesis type 1, repair versus replacement. So as we already know, Boston KPro has recently gained increased success. However, we still face many problems, especially regarding the complications that occur after KPro implantation. Of the most common complications, we have retroprosthetic membrane, glaucoma, and corneal melt, which will be our main focus in this study. So corneal melt occurs due to stromal thinning, which will lead to aqueous leakage, hypotony, endophthalmitis, retinal detachment, choroidal hemorrhage, or prosthesis extrusion. It occurs mainly in 14 to 16% of patients with KPro. Several predisposing factors can lead to the occurrence of corneal melt, such as retroprosthetic membrane, infectious keratitis, and the presence of inflammatory disorders and severe dryness. The main purpose of this study is to analyze the outcomes of patients with corneal melt treated with repair versus replacement to determine the optimal management strategy for future cases of corneal melt. We have no conflicts of interest. So our patients had undergone KPro placement by a single surgeon, Dr. Dagher, between 2008 and 2014. The KPro was of 8.5 millimeter diameter, made of PMMA with 16 fenestration. Corneal melt had occurred in these patients and were managed by either repair or replacement. Repair was done whenever we had the mild melt or no access to KPro. Repair methods included glue placement, amniotic membrane patch, or corneosclear patch graft. Replacement was done by a replacement of the KPro and implanting a new KPro and graft. Replacement was done in patients who have severe melt, infectious component, or extrusion of the KPro. Recurrent episodes of melt were considered as separate cases when melt recurred after the first episode was treated and healed. So patients were stratified into several groups: primary repair, secondary repair, and all repair, combining those two groups. On the other side, we have primary replacement, secondary replacement after a trial of repair, and all replacement, combining these two groups. In the statistical comparisons, we compared site or globe-threatening complications, including retinal detachment, choroidals, endophthalmitis, and phthisis. We also compared the risk of recurrence of melt, device retention rate, and mean BCVA before and 3 months post-operatively. We also looked at pre-melt and final BCVA in primary versus secondary replacement after a trial of repair to see if delaying the replacement and trying a repair procedure before opting for replacement can affect the final visual outcome. So we had a total of 19 eyes from 19 patients with a mean occurrence of melt at the 3-year follow-up. They were divided into 6 patients who underwent replacement and 13 who underwent repair. Of the 6 patients who underwent replacement, 2 needed a secondary replacement procedure due to recurrence of melt. 4 retained the KPro until the end of our study and their final follow-up. In the 13 patients who underwent repair, 6 required a secondary replacement due to recurrence of melt. 1 needed a secondary repair procedure due to recurrence of melt as well. 1 retained the KPro until the end of the study and the final follow-up. Whereas 5 lost their eyes with phthisis, evisceration, or extrusion. This added up into a total of 28 episodes of corneal melt, divided into 14 in each group. When we compare the demographics, we can see that the age and gender did not have any statistically significant difference between repair and replacement groups. The most common indication in both groups was anorexia. So now we come to our results. We had no difference in eye-threatening complications between primary replacement and primary repair. We also had no difference in the occurrence of complications in primary versus secondary replacement after a trial of repair, which shows us that delaying replacement and attempting repair does not affect the risk of occurrence of complications. On the other side, we also compared visual acuity by comparing BCVA before and 3 months after the procedure, and we had no statistically significant difference between repair versus replacement and between primary versus secondary replacement after a trial of repair. We also had no difference in change of BCVA pre-melt and at the final follow-up. between primary and the secondary replacement after a trial of repair. And here it also shows us that delaying replacement and attempting repair before going for replacement does not affect the final visual outcome. On the other side, we had higher recurrence of mild after repair versus after replacement, and we had a higher mean survival of the implant after replacement, which shows us a superiority for replacement over repair. This was attributed due to the when we do repair, we are changing the graft. The donor graft gives us a new base of tissue, which will disrupt any ongoing inflammation. And during the procedure, we also definitely removing the retroprosthetic membrane, which is one of the main predisposing factors for the occurrence of MELD, which will hold any ongoing process of MELD. This figure shows us a better survival in the replacement group in comparison with the repair group. So now we come to this algorithm, which we put to guide us in choosing the best management method whenever we have a corneal MELD in our patients. So whenever we have a corneal MELD with either extrusion of the KPro or an infectious component, we should directly go for KPro replacement. Also, whenever we have an availability for a KPro graft, regardless of the severity of MELD, we should also go to the KPro replacement. In cases where we have no access to KPro or graft, if the MELD was mild or we had only a mild leak, we should go for either glue or amniotic membrane patch. In cases where we have several clock hours MELD, we should go for a tectonic corneal graft. So as a conclusion, replacement of KPro for MELD is more beneficial than repair methods, and this is because we have a higher rate of device retention in replacement groups, and we have a lower rate of MELD recurrence. In certain cases, as we already said, such as extrusion or uncontrollable infection, we should always opt for a replacement. However, we should never delay treatment. So if we have a patient presenting with corneal MELD and we have no access to a KPro, we should go for one of the repair methods depending on the severity of the corneal MELD and how much clock hours are involved in the MELD. And this is because we had a similar final visual acuity when comparing replacement and repair, and we had similar rate of globe-threatening complications. We can consider putting these patients who undergo repair on the waiting list for a possible KPro exchange, since we have a higher chance of MELD recurrence when we do repair. Thank you.
Thank you very much, Roy. So it is an important topic. Luckily, it doesn't happen very often, but it's nice to have this algorithm to guide us in the management of these patients. Next is another important topic. Dr. Christina Bostan will speak to us about endophthalmitis post-KPro surgery.
Thank you for the introduction and for the invitation to present today. I will share my screen with you. Should be this here. So can everyone see my slides?
Yes.
Yes, very well. Thank you.
Great. So I will speak about endophthalmitis in eyes with Boston type 1 keratoprosthesis, and this is a study that was conducted with the help of my co-residents, Drs. Taylor Naiman and Andre Zigiato, and a past cornea fellow at our university, Hussein Morfek. So, since by its design, the Boston Keratoprosthesis bridges the non-sterile ocular surface and the sterile intraocular space, it is associated with a lifelong risk of infectious endophthalmitis. Reported prevalence of this devastating complication, threatening sight and globe integrity, vary between 2.9 and 15.5% over up to 47 months. Sorry about that. In this study, we aimed to determine the incidence and recurrence rate of KPro-associated endophthalmitis, its microbiological profile, risk factors, and impact on surgical outcomes in our cohort at the SHUM. We retrospectively reviewed 158 consecutive KPro procedures performed at our institution between 2008 and 2019 that were followed for a median of 7 years. All patients were maintained on topical steroids, topical 3rd or 4th generation fluoroquinolones, and extended wear contact lenses indefinitely after surgery. Cases with KPro-associated endophthalmitis were identified using a clinical definition of sudden decrease in vision, painful red eye, and vitritis, independently of the vitreous culture result. We distinguished endophthalmitis from sterile vitritis, which presented with painless loss of vision in a white eye with vitritis, and that resolved with steroids alone without administration of intravitreal antibiotics. All endophthalmitis cases were promptly managed upon presentation with a tap and inject, and when judged severe, with a pars plana vitrectomy. During the study period, we had 14 first episodes of endophthalmitis at a median of 19 months after surgery, with an incidence rate of 1.7% per procedure year. 6 of these episodes were culture positive, yielding an incidence rate of culture positive endophthalmitis of 0.7% per procedure year. 2 eyes developed recurrences at a rate of 6% per procedure year. The probability of an endophthalmitis episode was of 6% at 2 years, 9% at 5 years, and 11% at 7 years. Out of all the 18 episodes, including first episodes and recurrences, Streptococcus and Staphylococcus species were the most common, isolated in 32% and 17% respectively. Gram-negative pathogens and fungi were isolated in 1 case each only. 5 specimens were culture negative and 2 had not been cultured. The most important and strongest risk factor identified for KPro-associated endophthalmitis was ocular burns as an indication for KPro, with a 7-fold increase in risk when compared to other indications, followed by postoperative infectious keratitis, postoperative sterile corneal melt, and continued postoperative contact lens wear as opposed to their discontinuation. Notably, a history of blepharitis or prior glaucoma intervention, postoperative antibiotic discontinuation, and use of 3rd as opposed to 4th generation fluoroquinolones did not emerge as significant risk factors. To assess visual outcomes, we looked, as in the other previously mentioned studies, visual failure, which was defined as sustained worsened preoperative visual acuity after surgery. When comparing eyes having and not having developed endophthalmitis, in dashed here endophthalmitis and in full line here no endophthalmitis, we found that there was no difference between the 2 groups in terms of risk of visual failure using Cox proportional hazards ratios. However, up to 71% of eyes have lost at least 2 lines of Snellen visual acuity during their infectious episode. Of those having achieved vision of 2200 postoperatively, 50% could not recover it after the resolution of the endophthalmitis. 21% of cases have progressed to complete loss of vision. As illustrated in this histogram, while the final proportion of eyes with visual acuity of 2200 was superior to baseline in eyes without endophthalmitis, this was not the case in the endophthalmitis group, where the difference between final postoperative and preoperative proportion of eyes with 2200 or better vision was not statistically significant. Eyes with endophthalmitis, again in dashed, were 3 times more likely to not retain the keratoprosthesis and up to 7 times more likely to not preserve the eye and to undergo evisceration than eyes without endophthalmitis. To conclude, The incidence rate of KPro-associated endophthalmitis in our fluoroquinolone alone cohort were in line and even lower than some of the cohorts on vancomycin comprising regimens reported in the literature, as you can see in the table here. In contrast to these, where gram-negative and fungal infections are an increasing concern, most cases in our cohort were due to gram-positive bacteria, with only one fungal case and one gram-negative bacteria case. Vancomycin may be of particular benefit, however, in higher risk eyes, such as those with ocular burns, as demonstrated by our findings, or with autoimmune cicatrizing diseases, as already reported in the literature. Extended wear contact lenses are beneficial early after surgery, as they promote healing and biointegration, but increase the risk of endophthalmitis in the long term and should be maintained only in eyes at higher risk of corneal desiccation and melt. Despite prompt treatment, outcomes in KPro eyes with endophthalmitis are inconspicuous in terms of vision, device retention, and eye preservation. Since they increase the risk of endophthalmitis, infectious keratitis, and corneal melts should be aggressively treated in these eyes. In those that do develop endophthalmitis due to the high stakes and the frequent bilateral blindness, a lower threshold for pars plana vitrectomy may have to be considered to optimize outcomes, although this remains to be demonstrated in a formal study. Thank you.
Thank you so much, Christina. Excellent talk. Very, very comprehensive. It's wonderful to see it and hopefully soon in publication. The next talk is by Dominique Geoffrion, who's an MD, PhD student with us right now, who is working diligently on actually trying to understand glaucoma in KPro. Dominique?
Yes, thank you. I don't think I can share my screen for now. I think Christina is still on it. I'm not sure. Christina?
I'm trying to unshare, but I just don't know how.
Next to the green, there's a red on the top.
Okay, stop share. Okay, sorry about that.
No, that's fine. Thank you.
All right. Okay, is it okay? Can you see my slides?
Yes, perfectly. Thanks, Dominique.
Okay, awesome. All right. So, so thank you very much for the invitation. I'm very honored to be part of this wonderful group. I'll present our research on glaucoma outcomes following the Boston KPro. I have no financial interests. So today, glaucoma is still the most significant threat to vision in KPro eyes. And so the objective of our study was to evaluate and better understand glaucoma outcomes of the KPro, including protective and risk factors for glaucoma development. We looked at all the patients who were operated for KPro surgery between 2008 and 2017. We analyzed 118 eyes that had a minimum follow-up of 6 months and that were the first operated eye for patients with bilateral KPro. We compared 17 eyes without any glaucoma to 101 eyes with glaucoma. The baseline characteristics of these two groups were similar overall, but using univariate analysis, we found that older patients and female patients undergoing KPro are at higher risk of having glaucoma. We also performed multivariate analysis using multiple regression to determine predictors of glaucoma among all pre-op characteristics. Age and preoperative IOP were identified as significant risk factors for glaucoma development. Moreover, the most common pre-op diagnoses were trauma and chemical burn for KPro eyes without glaucoma, and pseudophakic or aphakic bullous keratopathy and aniridia for glaucoma eyes. We looked further into KPro preoperative diagnoses, and we grouped them in categories. By survival analysis, we found that autoimmune diseases and ocular surface diseases precipitate de novo glaucoma development in comparison to certain other groups. Next, in order to examine the postoperative course of KPro eyes with glaucoma, we divided those eyes with glaucoma into two groups based on their glaucoma onset. 73 eyes had glaucoma prior to KPro surgery and 28 post-KPro. And these percentages were comparable to the ones in the literature. We then looked at post-KPro glaucoma incidence, which was 3.4 cases per 100 eye years at 2.1 post-operative years. We next examined visual and glaucoma-specific outcomes of these three groups. Final BCVA was actually the best for post-KPro glaucoma eyes compared to pre-KPro. And then we also compared eyes with pre-KPro glaucoma onset to those with post-KPro glaucoma onset. The number of eyes with glaucoma progression or post-op glaucoma surgery, in green, were similar between groups. In the post-KPro glaucoma group, a greater proportion of eyes used an increased number of IOP-lowering medications, but less eyes progressed to a high cup-to-dis ratio. When we examined maintenance of postoperative visual acuity over time, 86% of eyes achieved a visual acuity of 20/200 or better at 12 months. The eyes with post-KPro glaucoma were the ones that maintained that VA the longest, while eyes without glaucoma had a 50% probability of maintaining that VA at 4.8 years. When we compared postoperative complications between the three groups, KPro eyes without glaucoma had a significantly higher rate of serious vision-threatening complications. In conclusion, a minority of KPro eyes are spared from glaucoma over the course of follow-up, and they are younger, of male gender, and have lower preoperative IOP. Autoimmune and ocular surface diseases precipitate post-KPro glaucoma development compared to other pre-op diagnoses. KPro eyes without glaucoma do not maintain better BCVA nor achieve better final BCVA, and they're at high risk of serious vision-threatening complications. In spite of all medical and surgical interventions, a majority of KPro eyes will likely suffer from definite glaucoma progression, whether glaucoma is arising before or after KPro. Thank you very much.
Thank you, Dominique. And Dominique is pursuing even more in-depth studies on the pathophysiology of glaucoma in KPro. Kashif, thank you for allowing us this extra 20 minutes. As you see, we're very passionate about our studies, and we actually are very grateful for the extra time that you have allowed us.
Of course, this is, no, I should be saying thanks, because this is really nice. And it's an amazing kind of synopsis within an hour of what the latest thinking is, evidence-based thinking is in KPros. Obviously, you've got a great amount of experience. I'm always impressed with what you've been able to do, not only as many of the people on this video meeting may know, amazing KPro work and research, but also a lot of admin work at the level of COS. If you think about the COS annual meeting, Mona's the one that organizes the whole thing. So it's a lot of stuff on your plate. So I'm very impressed with the team you've got and the work you've done. I'd like to open up the floor to some questions. And while people are thinking of questions, I do have a couple of my own, if you permit me to ask. One had to do with contact lenses. So what I learned was we should perhaps be looking at our long-term patients a little bit differently. So at what point in our patients that are low risk of having melts and come from etiology that's not high risk, at what point should we start thinking maybe not to use contact lens? How far after surgery?
Kashif, that's a great question. And quite honestly, today we could have actually had Jaru with us. She is now starting her residency in ophthalmology. She is beginning R1 in July. She has already worked on this project of contact lenses in KPro. What we have found is that during the first year, it's essential to have a contact lens. But after the first year, if the patient cannot tolerate it, it keeps falling, they're not able to be fitted for some reason, then it is not essential. So the contact lens is beneficial for protection in the first year, but after the first year, it's no longer essential. And as Christina has shown, it can actually increase the risk of keratitis leading to endophthalmitis. If it's avoided, sometimes it is better.
Okay. And of the contact lenses that are available, you have the wide diameter ones, the ones that are scleral lenses. Do you have preferences as to which one you find is most useful in the first year?
I have to admit, just by my training at the Mass Eye Near, the one that we use most often is the Contour contact lens from California. The one that we fit is 8.9 and 60 millimeter diameter. It has been the one that we resort to most often. We have it in clinics. Whenever they lose it, we place it on. And we actually get it with the KPro. Whenever a KPro is sent to be implanted, it's the lens that we use. But working with many different optometrists in Montreal, they have also found Biofinity to be very good. Some have fitted them with just AccuView, Johnson & Johnson, and it has worked well as well. It's whatever works in your hands, but we do prefer the Contour contact lens.
Okay. Now, I know there's a few glaucoma people in the audience, and as we know with KPro, you need a team approach. You have to have great retina colleagues and glaucoma colleagues. What is something that you would want to tell a glaucoma specialist when taking on co-managing their first KPro patient? What are some key points that you would want them to know?
The first key point is whenever I evaluate a patient for KPro, even before I operate them, I want to know their history of glaucoma. Have they used medications? Have they had surgery? I always consult glaucoma before operating to see what they prefer. Sometimes they like to do surgery for glaucoma before we proceed, especially if the pressure has been high and is not able to be controlled. Sometimes they tell you, go ahead and proceed, and then I'll do later on when I can actually see the optic nerve to see how far they've progressed with their glaucoma. It really depends on the surgeon who you're working with, and most often what I have found in my practice is that they will wait until you operate so that they get a better glimpse of the optic nerve, decide on the basis of the excavation what they should be doing at this point. When they operate, they like to operate doing a vitrectomy. They like to remove all of the vitreous and implant a tube. And in eyes that are very severely damaged by ocular surface disease, sometimes they actually resort just to CPC. And it has worked wonders. And although we historically think of CPC as a last resort, the eye is going to go into phthisis, we have a huge series of patients with KPro who have had CPC and have been doing very well. So we do as much as possible maximal medical therapy until that tube is placed in, whether it's pre-KPro or post-KPro.
Okay. And I guess any other questions? I had one last question, but I want to make sure we can entertain any other questions that people may have. One last question I have, Mona, is there's 75 to 90 people on this, 75 to 80 people on this web meeting. For some people who are about to think about starting KPro work or want to try their first KPro, what recommendations do you have now based on the information to kind of put together, frozen tissue, fresh tissue, what kind of cases, what kind of backgrounds, what tips would you have for them in terms of pearls for starting their first few KPro cases?
Start with easy cases. Start with a patient who's had a couple of grafts that have failed. Their glaucoma is well controlled. Start with a multidisciplinary team. Don't do this on your own. It's important to have a team of glaucoma, retina, oculoplastics, people who are around to help you, because you will definitely encounter complications. Build a very good relationship with your patients. They're going to be your patients for life. It's important for them to understand from the beginning that it is going to be a long road together. That relationship is important because they have to come back for follow-up. The first month, come back, post-op day 1, week 1, 1 month, and then after that, every 4 months for life. So it's important for them to understand how much it really will get them involved, engaged in the treatments. Aside from that, I say go for it. It does have good success in the right eyes. Avoid chemical burns, avoid Steven Johnson's OCPs at the beginning. Later on, when you're more at ease with it, it's fine to do so.
Great, thank you. A question from Dr. Etienne Bitton for Dr. Giaffion. You mentioned that ocular surface disease and autoimmune diseases are risk factors for success for the KPro. Can you please elaborate?
Yes, thank you. So I replied on the chat, but I'm happy to explain further. No, that's okay.
You're too quick.
So we found that these diseases, they precipitate glaucoma. They affect the proportion of eyes that remain glaucoma-free in comparison to the other preoperative diagnoses. So with pairwise comparisons, we saw that they affected the total proportion of eyes that remain glaucoma-free after the KPro surgery.
Okay, awesome.
Thank you.
Okay, well, I've definitely learned a lot. I'm definitely going to look at the way we, in my cases, we're looking at contact lenses, we're looking at melts, what we're going to do with frozen tissue if the need, if we have a scarcity of fresh stuff. So I've definitely learned a lot. Thank you so much to the team. Thank you, Mona. Thanks to all the attendees for taking time to participate in this. I will be sending out, as we get more established, we'll be having social media links, and this recorded session will be posted to our YouTube channel. And so I wish everybody a great evening. Thank you so much, Mona.
Thank you.
Thanks for your leadership in this area, not only in Canada, but in the world. And I look forward to seeing you in person one day, hopefully soon. So be safe and have a great evening.
You too. Thanks so much for the opportunity.
Okay. Bye-bye, everybody.
Thank you.
Thank you.
Bye.
Sorry about it. My headache was like, oh, just a moment. Oh.
Javiera. All right. Leandro. How's it going? You doing okay?
Yeah, everything is.
I wanted you to, you know what, I should turn the recording off. 1 second.